Hey, Dr. Joe here at Atlas Health. Happy Friday. Broadcasting live here in Fairfax, California, and really excited to share with you part 3 of why do I have thyroid symptoms even though my lab tests are normal. And so a couple of quick announcements. We're doing these videos because we get a lot of questions here every day, like, man, I wish I would have known this before. And, this is amazing information, and why aren't more doctors doing this? And is there anything that we could do to learn more about this stuff? And so because we're having so many conversations every day about the thyroid gland, we decided to, myself initially and Ms. Flanagan decided to do a couple live broadcasts about different topics. And so I wanted to continue on with thyroid broadcasts. And so this is part 3 of our series. And can everybody see me out there? Just want to make sure everybody can see me. Okay. So anyway, what we're going to do today is go over part 3, which is related to the liver conversion of thyroid hormone and also related to the peripheral utilization of thyroid hormone. So this is the part where I give a disclaimer. And just say hello if you can see me on there. Sometimes we have an issue with people not being able to see me. So can somebody comment? Okay, cool. Thank you, Stacy. Just want to make sure. So in part 1, actually, let me go through the disclaimer first. So I just want to be clear that this video, I have to do this now, is that it's not constituting medical advice, okay? A lot of people are just really tired, and they're really depressed, and they're really constipated, and they have all these digestive issues and autoimmune issues they're not resolving. They've been told they have Hashimoto's, and they've seen medical doctors and had, been given drugs, and they've seen traditional doctors, and they've tried a lot of different things, and they've seen alternative doctors, and they've tried a lot of different protocols for thyroid, like taking iodine, or maybe they're taking some tyrosine, or maybe they've taken cofactors or selenium or something, and they're just not getting the results they're looking for, okay? This is an educational video designed to help people understand why that is, okay? It's not the same thing as constituting medical advice, and I just want to be clear that I'm not a medical doctor. I am not an endocrinologist, so I will not be able to prescribe medicine for you or treat your thyroid gland, okay? And as a clinician in functional medicine, I actually do not treat the thyroid gland. What I actually do is I help people understand the physiological issues that are going wrong that are now allowing the thyroid hormone to function optimally, or the thyroid gland to function optimally. So I'm basically doing nutritional and clinical support of the physiology of thyroid function, not treating thyroid disorders with a thyroid hormone, okay? So I just want to be clear about that language. I know that most of you that know us here at Atlas Health are aware of that, but for those of you that don't know, I'm not a medical doctor, and so that's the disclaimer. Okay, this information is based on a book written by a colleague of mine, Datis Karazian, and he wrote a book called Why Do I Have Thyroid Symptoms Even Though My Lab Tests Are Normal? And so it's a pretty awesome book, and so if you're looking for a little bit more information on this, check out that book. A couple of announcements. My next class is going to be, it's not scheduled yet, but it's probably going to be in about 2 weeks. I'll be doing part 3 of, why do I still have SIBO and digestive disturbance, even though, diet and supplements didn't help me. So we're going to be talking about part 3. If you recall, part 1, we talked about the amygdala response and its association with fear, anxiety, generalized anxiety disorder, worry, and its relationship to keeping blood out of the gut so it can't heal. We talked a little bit about its attachment. And then in the second one, we talked about serotonin. And in the third one, we're going to be getting into energy and GABA and its impact on that whole scenario related to the amygdala. So really excited to be talking about that. That's going to be in about 2 weeks. And okay, so let's just review a little bit about the thyroid physiology. We talked about, just to kind of bring us back up to speed here. Okay, so we talked about the physiology of how the thyroid gland gets its signal from the hypothalamus. It goes to the pituitary gland. Pituitary gland releases TSH. TSH tells the thyroid gland to take 2 iodine plus 2 tyrosine and make T4, excuse me, and it makes a little bit of T3. And then T4 goes to the liver and gets converted to T3, reverse T3, and T3S and T3AC. Okay, and then what happens after that is the T3 then goes to the receptor, thyroid hormone receptor, activates that receptor, and that receptor basically it activates the DNA of that cell, and they have energy. That's kind of a basic summary of that whole scenario. Now, there's little nuances of that where these proteins, when they're made first, they're bound. And then once they get to the tissue, the binding goes away, and they're now what's called free. Okay? So if you're doing lab testing, you might have heard like a total T3 versus a bound T3, or a total T4 versus a bound T4. Okay? And so the first session, we kind of outlaid the 22 different patterns of thyroid disturbance that can contribute to thyroid symptoms. And the second video, we talked about the 5 patterns of secondary hypothyroid related to low TSH. Okay, so sometimes what happens is you can have a failure here, you can have a failure here, you can have a failure here, and you can have a failure here. Okay, so the first time we kind of outlaid everything. The second time, we spoke a little bit about the brain and its relationship to thyroid function. So we said if a person has low TSH and they have low T3 and low T4, both, then they may have what's called a secondary hypothyroidism due to 5 different patterns. And we talked about those 5 patterns being 1, a prolactinoma, which is a tumor in the pituitary gland, which might cause somebody to have peripheral loss of vision and producing like breast milk when they're not pregnant or lactating. 2 would be related to high cortisol and suppression of the pituitary gland of the brain just from having a high stress response. 3 would be not enough dopamine and serotonin neurological projections into the hypothalamus. Okay, 4 and 3, so that's 3 and 4. And then 5 would be cytokine elevation, meaning when we have white blood cells that are affecting our own tissue or perhaps an infection and they're constantly talking, they produce these chemicals, and those chemicals go to the hypothalamus. And the hypothalamus does not get the pituitary signal. And so we have low TSH, low T4, low T3, and therefore we have all the symptoms of thyroid issue, but we have a problem where the brain is not getting the signal, but the thyroid gland is actually just waiting for the signal, and if it got the signal, it will be fine. Okay, and so we talked about there are ways to use like history. So for example, if a person has a little more depressed type of hypothyroidism and they're fatigued, and they have brain fog or migraines or like more neurological type symptoms, maybe they have that secondary, that might be a thing to look at in the history. So now we're going to transition a little bit more into the area down here. Okay, so let's say that the TSH is normal, person's making good thyroid hormone, their T3 and their T4 is normal, okay, or their T4 is normal, I should say. And so then T4 goes on into the thyroid, goes into the liver, okay? And now the liver has to do this. There's an enzyme there called 5' deiodinase, okay? And its job is to convert thyroid hormone into another type of thyroid hormone called T3. So T4 gets converted to T3, okay? And T3 is actually the hormone that we use to activate our thyroid hormone receptors that give us energy and help our tissue repair and so on. So this conversion is like a really, 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 really big deal. Now, sometimes when I am taking a history and I start talking to somebody and they're like, yeah, I'm just really tired and I'm constipated. And yeah, I have hemorrhoids. And yeah, I have some chemical sensitivity. And, you know, coffee really, I don't tolerate coffee very well. And I don't tolerate alcohol very well. And, you know, my skin isn't so good. It kind of itches, or they have acne. And maybe they had a history where they work like in retail, where they're around like, you know, dry cleaning material, like on all the clothes, or they work at a garage, and so they're constantly exposed to industrial chemicals, and you start to get this history of, kind of like a liver type history, right? And then so then I look at the forms, and the forms are like, pretty high in the liver section, meaning we have people fill out these forms and they're 0, 1, 2, and 3, and they're kind of high in the liver section. But they actually look okay in like the brain endurance section. So maybe they're not so depressed so much, but they're just more like showing some loss of chemical tolerance and constipation and fatigue, right? So maybe they're not having a migraine or like depression or, brain fog, okay, but maybe they're having more hemorrhoids and itchy skin and acne and, constipation, and they don't tolerate alcohol and caffeine very well, and they tend to like take a drug that's prescribed to them and they have a reaction to it. They react to everything. Okay, maybe they have allergies and that kind of thing. So that might be like, I wonder if this person has thyroid symptoms because they're not converting. Okay, and so the way that we can determine this is we look at their thyroid hormones, and this person here might have a really good looking T4. So the thyroid makes normal T4, okay, and then it goes to the liver and it gets converted to T3, but T3 is kind of low, okay? So this step here where the T4 converting to T3 isn't happening, or it's happening very inefficiently. This enzyme called 5'-deiodinase isn't doing its job, okay? Now, 5'-deiodinase doesn't do its job for various reasons, okay? Some of the reasons, 3 of the reasons, 4 of the reasons are almost identical to some of the brain stuff that we talked about. So a person may have a 5'-deiodinase issue due to a lack of cofactors. Okay, so this does happen where a person may become depleted in some minerals and some amino acids that are necessary to drive this physiology. And so there's a solution for that. Okay, there's a way to look at labs and go, okay, it doesn't look like these other factors. It looks like this is a nutrient issue. For example, if somebody is vegan and they've been depleting themselves, or they've been on several medications for a really long time, and maybe they depleted their liver, or they've been on hormone replacement for a long time and they depleted their liver, and they're just not efficient in their liver, and that's kind of in the history. But some of the other stuff that we might talk about later on isn't showing up. They just might need some cofactors. Okay. Another pattern. So we'll just say this. We'll list one pattern here as cofactors. Not enough cofactors. Okay. 2, another thing that could be happening there is that they also have 2 and 3 is low peripheral dopamine and low peripheral serotonin. So for the same issue that's going on in the brain, if that serotonin and dopamine issue continues on in the periphery outside past the blood-brain barrier, then they may not have a very good conversion response. Okay. Another thing that can cause a problem here is related to cytokines again. Okay, so when we get those cytokines elevated, meaning if the white blood cells are talking a bunch because they're attacking our own tissue, or because we have a chronic infection like Epstein-Barr, for example, or Candida, or an H. pylori infection in our stomach, and we just haven't been able to kick it, it's been kind of hanging around, and our immune system's constantly talking. Or, for example, if you have Hashimoto's and your immune system is attacking your enzymes that make thyroid hormone, then that's a problem. And so you're getting the systemic inflammation, which is now affecting 5'-deiodinase, and you're not able to actually convert your thyroid hormone, and you get a thyroid hormone conversion issue. So you can see that if you make T4, but really it's T3 that activates the tissue, and you're not converting T4 to T3, that you're going to end up getting thyroid symptoms, right? So you could have a normal T4, you could have a normal TSH, but then the conversion of T4 to T3 isn't happening, but T3 is what our body uses primarily for most of the functions related to thyroid gland, related to energy. And so now T3 isn't being made, and so there's still no T3 happening, or not enough. And so this person may do a TSH test at their regular doctor, and their TSH looks normal, and the doctor says, you're fine. But they have all the thyroid symptoms, okay? And they're still having all the thyroid symptoms because they're not converting T4 to T3 in this case, okay? Another thing that commonly happens is a person may have primary hypothyroidism, okay, where they have high TSH, and they actually really need thyroid medicine. So they have high TSH and low T4, and then basically they take Synthroid, or they take levothyroxine, or even they take a bioidentical T4, and they feel better for a little while, but then they plateau, or they take it and they don't feel better at all, but their TSH goes to normal. So it's like now their lab tests are normal, their T4 goes up from low, and their TSH goes down from high, and they're like, wow, my labs look normal now, but I don't feel any better. And that might be because their liver is not converting that medication to T3, which is the active form, okay? So this is a person that goes on a NatureThroid or Armor or something like that, that's more of a T3 type supplement, or medication, I should say, not supplement. And they feel like rainbows and unicorns came out. It was like the best thing in the world, okay? Because they had a problem in the liver converting their T4 to T3, they go on to T3 and medication, and they just feel awesome, okay? And so that's one scenario that, in my mind, might suggest they have a conversion issue, okay? So that's kind of good to know. Now, if we start investigating the causes of the conversion issue, we could say, is there a deficiency in cofactors, which is not as typical as one might think, okay? Is there an issue with dopamine and serotonin, okay? Is there an issue with cytokines again, okay? And is there an issue with cortisol again? Okay, because when cortisol is high, that messes up this enzyme that causes this conversion, okay? And then progesterone has a role in this whole thing too, okay? We're not going to talk too much about that right now, but progesterone definitely has a role in that. So what we want to say is, how do we figure this out? What's causing the 5' deiodinase issue? Okay, well, if we look at, if it's cytokines, the person may have a white blood cell count that's either high, suggesting current infection, or low, suggesting chronic infection. They may have a distribution of white blood cells suggesting they have a candida issue or a virus or a parasite. We start looking at that, and we start affecting the immune response, and the conversion issue corrects itself, okay? If they have low dopamine and serotonin, again, we start looking at that old story, and if you haven't had a chance to check out that video, it's part 2 of this series, where we look at how the brainstem, this area, which makes dopamine, and how this area, which makes serotonin, can actually be developmentally delayed, or it can be asymmetric from one side to the other, or the person is just not exercising enough, or they're exercising too much, or the person's perhaps had a concussion, and now there's an issue with both the ascending and descending projections of dopamine and serotonin, and that release of neurotransmitters is happening, and now they're having all these thyroid symptoms, but they're brain-based, okay? And so again, there's really no efficient way of measuring this happening in the brain, but some of the neurotransmitter testing that a person can do for neurotransmitters, there's a couple labs out there that do the urinary testing. That testing could be useful as far as this pattern goes. Okay, so that's one way that we can look at peripheral concentrations of dopamine and serotonin, keeping in mind that, again, if the liver's inefficient or the kidneys are inefficient, then we may not get accurate readings there. So I don't know, I'm not a big fan of those tests in general. I like to go more on history and symptoms. So like if this person's like depressed, but they're like having trouble getting motivated and finishing tasks, and they're a procrastinator and they're craving chocolate and stuff all the time, they maybe have a low dopamine issue and they have a dopamine depression. If this person's like wanting to isolate themselves and they don't enjoy foods anymore, they kind of lost their zest for life, they're having some sleep disturbance, they're waking up in the middle of the night, and they're having a little tendency to having obsessive thoughts, that might be a serotonin type pattern. And so we might be considering some things that we look again at the brainstem, or we might consider some nutritional support for serotonin, okay? And that would help their thyroid conversion. So that's kind of cool, right? Because basically we can give nutrients that just support thyroid conversion, okay? There's supplements for that. It's kind of cool. We can give nutrients that just support the cofactors for thyroid hormone conversion. And that's really, 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 really useful in people, for example, that are taking thyroid medication and they're showing a pattern of lack of conversion from T4 to T3. That actually can dovetail very nicely if you have a relationship with your medical doctor and your medical doctor signs off on that. then it can be a great thing for folks, okay? So that's kind of some of the things that affect the peripheral conversion of T4 to T3. Now, one of the things that can happen in this conversion process is to say that sometimes as we convert, we actually end up having more bound hormone versus free. And this is kind of a tricky concept, but remember that the circulating hormone, for our hormone to get from our thyroid gland to our tissue, to every cell in our body, it like jumps on a bus basically, it gets chaperoned. And then once it gets to the tissue, we don't know how this happens exactly, but the chaperone just says, okay, you're good to go. They jump off the bus and they become free. So they're a free hormone level, okay? And so some people have an issue where they make T4 and they're converting it all to T3 just fine, but it's all bound. And so now the deal is this. You got all this bound T3 circulating and it's like hovering around all of the different receptors. And so, but they're still not getting activation of their tissue because they can't get off the bus. It's like the chaperone isn't letting them off the bus. And so this is really commonly caused by high estrogen. So this is the gal that goes on birth control, and she's taking like Yasmin or any like estrogen based hormone replacement, and that's what going on the pill is. Or they say they're going through perimenopause and their doctor just says, yeah, you need some estrogen, and or they're in menopause and they're just getting like brain fog and migraines and insomnia, and they're just going kind of nuts. And the doctor does a test and they show they have low estrogen. And so the doctor puts them on like a bioidentical estrogen, or they may have done some research and they get on like some wild yam or something that increases their estrogen. And the thing is like we make estrogen in picograms, which is like if you filled a train 6 miles long full of water, each car, and then you put one drip of water in that entire train, that's a picogram, okay? But then when we take the patch or the ring, the estrogen dosed in those things are in micrograms, which is like 1,000 times more powerful. So imagine you have an estrogen receptor and you wanted to go shake hands, and that's picograms, okay? And then you had an estrogen receptor and you wanted to go shake hands, and there's so much of it circulating. It's like it's the person that shakes your hand and it's too tough and it just crushes the receptor and it like crumbles. And like that jerk who like shakes your hand and they're trying to be cool and they're like, it's like, dude, come on, man. It's like what's the macho handshake all about, right? And your hand is like, okay, cool, way to prove your point. You know what I mean? That's like the high estrogen hormone pharmacologically introducing, like damaging the estrogen receptors, and they downregulate, they stop circulating. But what ends up happening is that high estrogen circulating in the tissue creates a increase in bound thyroid hormone, and that bound thyroid hormone issue actually doesn't allow the thyroid hormone to jump off the bus, and so now they have bound thyroid hormone. So, and they have, what that'll look like, it'll be normal T3, total T3, but decreased free T3. And when you look at labs, okay, you might find this. T3 uptake will be low, okay, meaning there's not free T circulating to be taken up by the tissue because it's all bound. And so that's the person who goes on the pill and they gain like 30 pounds in a year or in a few months. And everybody knows somebody like this, okay? They are trying to, be responsible with family planning, and, they're not ready to have a child, or they have hormone symptoms. And so the standard of care right now for a cycling female that has any hormone symptom at all is to put them on the pill. Really without any, I'm not saying that's a bad model. I'm not trying to disparage any other doctors, but I'll say this, that's one way to approach it. Okay, no questions as to why there's cycles all over the place. Just put you on the pill. Okay, and one of the negative consequences that unfortunately is it can create a secondary hypothyroidism through bound versus free levels, and that poor girl will get depressed. She'll gain 20 pounds. She'll be constipated. She'll be fatigued, and that works pretty good for birth control because they're really not interested in sex anymore. You know what I mean? It's probably not the mechanism they had in mind, but that's pretty much what's going on there, okay? So in that situation, We have to identify where the estrogen source is coming from, and then we have to help them make an educated decision about what they're going to do with that. Sometimes we need to help them clear estrogen, and sometimes people are making more endogenous estrogen because they're just stressed out of their mind and they're estrogen dominant. So, and that individual with normal T3, so they're converting fine, but they're converting to more of a bound T3, then we have to go through this whole story if it's a cycling female about what's going on with their estrogen surges and the fluctuation of hormones. If it's a menopausal female, we have to talk about the adrenal glands and what's going on with estrogen there. We have to talk about hormone replacement. And if it's a male, it's the same thing. We look at estrogen levels. We do, saliva testing or hormone testing for that. And that's a really nice way to measure those things. Okay, so you can see how this stuff can get kind of confusing if you're only looking at TSH. Because in that scenario, TSH could be completely normal. But what's happening is you're making T4, you're making T3, you're converting T3, but T3 is now bound and not free. So your T3 levels are normal, but your total T3 is normal, but your free T3 is low, and you express all the thyroid symptoms, even though your lab tests are normal. Okay? So look, you could put somebody on a liver detox for that, okay, possibly. But here's the deal, it's really easy just to give a supplement for the pattern that you find. So if you find a conversion issue, it's really easy to diagnose a supplement. It's not easy to get to that point where you're diagnosing the pattern. That does take some work. It took us a while to figure this stuff out, okay? And I've had some excellent teachers to help me along the way, but I'll say that once you identify the pattern, it's really, okay, give that supplement. That's a great first step. But the real work of remediating the functional thyroid disturbance is understanding the lifestyle factors that contributed to that issue to begin with. Okay, so we really need to look at stress responses. We really need to look at sleep. We really need to look at food. We need to look at environmental toxins. We need to look at the immune system. We need to look at developmental issues. We need to look at attachment issues and development of the brain and something called vigilance. We need to talk about concussions. And we need to talk about whiplash and prior injuries. And we need to talk about PTSD. And all these different things contribute to a constellation of a loss of one of these patterns of thyroid disturbance. And we can give a supplement to help support the physiology of the underlying thyroid issue, okay, and a secondary thyroid issue where it's not a thyroid disease, okay? But if it's a thyroid disease, and it's a primary hypothyroidism, then the standard of care has to be consulting a medical doctor and getting a prescription for that, okay? That's why I say I don't treat the thyroid gland, okay? That's how you treat the thyroid gland. If TSH is high and the thyroid is not responding and T4 is low, that's called primary hypothyroidism, and that person requires a prescription medication, at least until that person can figure out why that happened, okay? Now, for the person that had primary hypothyroidism, they go on their medication, which is T4, their TSH comes down to normal, and their T4 goes up to normal, but they still have all the thyroid symptoms. They start looking for answers. And they're not getting an answer because they're told that their lab tests are not normal and it's in their head. They're just depressed. Why don't we put you on some Prozac? Okay, now, you know what? Prozac might be really, 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 really good if that person actually has the brain issue that's contributing to the loss of serotonin, both in the brain, projecting to the hypothalamus, and into the periphery, causing, helping that liver conversion. But here's the deal. If the person doesn't have low TSH, it's probably not going to be a primary serotonin issue, right? That's how you know the difference if they should be going on prescription medicine or not. And again, I can't prescribe prescription medicine, but people come in here all the time and we have to try to figure out what the heck's going on, okay? So for that person that went on the pill, or they went on a medication and they just gained weight like crazy, it might be that their liver got tied up with that medication and they're not converting the thyroid hormone very well. And we do a complete pattern where we look at TSH, total T4, total T3, free T3, free T4, reverse T3, and we look at something called T3 uptake, and we can get a complete panel. Now, the last thing I want to say about the thyroid hormone conversion, okay, is this. We talked about T3S and T3AC. Okay, that goes to the bowel. and then that gets converted to T3. So some people, they make T3S and T3AC, and then it goes to the bowel, and they have like candida, or they have too many good bacteria in the wrong place. It's called SIBO. Or they have too many good bacteria in the right place, and it's called a commensal bacteria overgrowth, okay? Or they have a parasite, or they have some sort of really significant bowel issue, okay? And because of that inflammation, they have IBS, or they have colitis. Because of that issue, they're not converting, and so now they get like subtle secondary thyroid conversion responses, and we look at their levels of T4 and T3, and they look fine. There's really not a very easy way for a clinician that's not super expensive to order T3S and T3AC. So in that scenario, we go, okay, well, it's not a T3 to T4 issue that we can see coming from the liver that we can support there. It's not a bound thyroid hormone issue that we can support there, meaning a bound T4 that is high compared to a free T4 or free T3, right? So we know that's not the issue. And then we look at them and we talk to them, and they have been diagnosed with IBS, and they have bloating after they eat, and they're massively constipated or have diarrhea, or it's alternating constipation with diarrhea, and the bloating is timed like an hour after they eat, or sometimes it's right after they eat. And we start to say, okay, this looks like a pretty significant bowel issue, and some of your fatigue and some of your thyroid symptoms actually are coming from a conversion issue that's taking place inefficiently in your bowel. And that's the person that goes on a bowel cleanse. They go on the master cleanse. They go on some major bowel cleanse, and all of their thyroid symptoms go away. Okay, and that's the mechanism. That's how that works. So we're not going to have time, unfortunately, to get into the peripheral receptor pathology. Okay, so I will do a part 4, and then I'm going to do. Actually, I decided I'm going to do a part 5, all about Hashimoto's and the autoimmune pattern, because actually, that's the majority of cases that there's a Hashimoto's pattern involved. So the next 2 videos that I'm going to do related to thyroid gland are going to be related to this pattern right here. Okay, and then it's going to be related to the Hashimoto's pattern. Okay, so let me just see if there's any questions out there that I can answer. Somebody asked me, hey, look, Dr. Joe, I just started a cleanse program. Do you do anything different with someone without a gallbladder? Okay, and I would say the gallbladder being taken out is a big deal as it relates to absorption of healthy fat, and it does affect clearance. And so when I see people have a history that their gallbladder has been taken out, I try to support them with bile salts and some other herbs like dandelion, stuff like that. I often use a product from Apex Energetics called Biomin, and we try to support them with every meal to help facilitate that process. So absolutely, when there's no gallbladder, we take that into consideration. Particularly, it's relevant during these conversion patterns because we're working a lot with the liver. So that's a great question. Another question is here. I have Dr. Smith, I have many issues that appear to be thyroid related, but my lab tests are always normal. So Stacy, I'd be really interested to see, what do your lab tests look like when we start looking at more than just TSH? And what does your brain exam look like as it relates to the brainstem production of serotonin and dopamine? Okay, and what is your medical history as far as, are you taking the pill, or did you ever take the pill, or have you had a concussion, or what was your relationship like with your parents, and is there any evidence of a developmental issue related to an infection when you were a kid affecting the brainstem, or what is your response to alcohol and caffeine? And some of those questions I might get into might help guide me into some of these secondary patterns from a history standpoint, but from a medical standpoint, looking at labs, we could say this. Did they look at all of your hormones? Okay. Did they look at TSH, total T3, total T4, free T4, free T3, reverse T3, and the TPL antibodies, and thyroid binding globulin antibodies, okay? And if they didn't look at all those, then you may not have had, in my opinion, a thorough thyroid assessment, okay? Once we identify here where the pattern of disruption is, now we can start investigating the secondary brain patterns or the secondary peripheral utilization patterns, and then we can use ancillary testing like white blood cell testing, like history and exam, like dietary questions and forms, like looking at adrenal and cortisol levels and things like that to determine, where's the 5'-deoxydenase issue if it's a liver issue? Where's the environmental toxicity coming from? Is there a history of the pill? That kind of thing. And so I would say, give us a call and we can sort that out for you, okay? All right, another question is, I've been on thyroid and it's helped because my labs are okay. I was taken off and those symptoms came back along with trouble losing weight. So I think thyroid medicine is awesome. And I have to tell you, one of the most frequent referrals that I give are when I see people here that have really terrible thyroid hormone levels and they want me to do natural things to help them. And I have to tell you, if you don't have good thyroid hormone levels and you're requiring medication, then nothing we do is going to work, okay? Because that medication is going to help provide you energy and the capacity to heal. So I'm a huge fan of thyroid medicine, and I refer all the time to medical doctors to get thyroid medicine. I also refer to medical doctors all the time to have people have their thyroid medicine changed from a T4 to a T3 if that's what their medical doctor agrees is the right thing to do. I also refer to medical doctors because sometimes people come in and they're taking thyroid hormone and they were just taking too much. And so they just needed somebody to look at their labs in a little more complete way, and they needed an advocate for them, and they go back to the medical doctor and they change their levels and they feel awesome. So that's a great point. One question is here, I tested positive for BRCA1 and a bilateral mastectomy. Okay, so that individual, they probably have some pretty significant estrogen issues going on, right? Okay, so it would be, if they had normal looking lab tests, we might want to look at T3 uptake in that moment. Okay, so that might be something I would consider, looking at T3 versus bound T3, T4 versus bound T4. Okay, that might be something to consider there. Okay, so in quick summary, there are 22 patterns of thyroid disturbance, functional patterns in the literature, okay? One of them, called primary hypothyroidism, often requires prescription medicine, okay? And that needs to be treated by an endocrinologist or a licensed medical physician, okay? For people that have thyroid symptoms but they're told their lab tests are normal and aren't on medication, are looking for answers, we can start to tease apart these different scenarios, okay? For people that have taken their medicine and they're still getting thyroid symptoms, that probably means that there's other issues that are ancillary to what's going on with their total levels, like, for example, a brain issue or a conversion issue or like an adrenal cortisol issue or an immune issue. And if we investigate those things with other labs with history and exam, and we can dial in on those and quantify them and objectively measure them, and we intervene specifically to support the thyroid physiology while we address the underlying mechanism driving that physiology, we often see that by supporting that physiology, that person's quality of life improves, which means the depression gets better, their bowel movements regulate, they're no longer feeling cold all the time, they're no longer feeling fatigued out of their mind, and they also can lose weight for the first time in a very long time. Okay, so if you'd like to get a hold of us here at Atlas Health, you can contact us at contact@atlas-health.net, okay? And that's our website, I should say, and that's our email, okay? So let me say that again. To contact Lindsay to learn a little bit more about what we do, contact@atlas-health.net, okay? So it's been a pleasure talking with you today, and I look forward to the next round. I believe we're going to be covering receptor-based pathology, and after that, we're going to get into Hashimoto specifically. We also started a YouTube page like last week, okay? It's Dr. Joseph Smith on YouTube. I think there's like 1 or 2 videos on there right now. And so for those of you who know people that aren't on Facebook that are just dying to see this stuff, let them know. And we do post other things on YouTube that we're not posting on Facebook Live. So if you'd like to learn more, I'd really appreciate if you follow us there so we can keep you on the loop and keep us all working together to get a greater healthcare system. So thank you for your time. We'll catch you next time.